When we coach each other, that's really how culture changes. We coach each other in terms of what kind of behavior we should or shouldn't have. That's the way just American culture, that's the way any culture works. It's how do we behave in our environment? How do we do things right here? So this is Team Steps. It's a curriculum from AHRQ. AHRQ is the Agency for Healthcare Research and Quality. It sits under CMS. So Marilyn Tavenner, when you've been able to see her sit in front of Congress lately, she sits under Kathleen Sebelius. It's Marilyn Tavenner at CMS, and then AHRQ sits under that. AHRQ was designed to almost be like a warehouse of healthcare data that people could go to and say, I've got this problem with quality care. What can I do about it? And so they put together this curriculum that's really from all those fields I talked about: oil platform business, healthcare, airline industry, nuclear power, and said, what is it that are the best things? What's the best evidence for this? Here's Team Steps in one slide, or at least a lot of Team Steps. Team Steps is an 800-page curriculum. That's your federal dollars at work. And so an 800-page communication tool is also your government at work. So the problem is not everyone's going to get through it. This is what you might want to take away with you, is that really to be a good individual, you know how I talk about all those permutations of teams. If you do 4 things as an individual, you're going to be a pretty good team member. And that is, the first one is you maintain situational awareness. You know your surroundings. If you've ever gotten off the elevator on the wrong floor, you've lost situational awareness. Most of us probably have lost situational awareness already this morning because it happens that quick. It's a very human condition. Second thing you've got to do is use standardized language. So in OB, the latest that we've had on that is NICHD language. Why did they do that? Because people were calling D cells too many different things. It became confusing. Like I said, if you've got so many different words for something, that communication can be misinterpreted. Just real quick, Christy and I were doing some work at the Minnesota Department of Health, simulating a disaster. A tornado struck in South St. Cloud. That was a scenario. And the Minnesota Department of Health does so many things. It's amazing, really, what they have to do. They have to get a morgue. They have to get food and water. They have to get shelter. So they do all of these things. During the simulation, one of the guys who was military said to the worker next to him, we need to get a water buffalo up to St. Cloud. She never challenged him, never said anything, and actually in the debriefing thought, well, do I have to go to the zoo to get a water buffalo? It was that bad. Well, in the military, a water buffalo is a big water tanker. So the more words and the more jargon that we use, the more we could get in trouble during an emergency situation because not everyone knows all the jargon, and that's why NICHD came up with that language. Closed loop communication, we already talked about that, but what I want to tell you is that it's a 3-step process. It's not verbal order readback like Joint Commission requires of the nurses back there. Don't you like it? Joint Commission will come and actually look over your shoulder while you're doing the verbal order readback. I always thought that was kind of funny. But it's a 3-step process. So if I say, I need 0.2 milligrams of Metrogen, the nurse repeats it, 0.2 milligrams of Metrogen, that's right. Third step is I acknowledge that what they heard was correct. Otherwise, you might get someone going off to get some different dose or different medication. And last is shared mental model. We all know where we're going. We all know what we're going to do. And it's really being on the same page. Why do I tell you all this stuff about Team Steps? Is because for your simulation, you have to train to a goal. So most of the simulation that we're used to, the goal is improving clinical practice in terms of actually, like the one I showed you, shoulder dystocia maneuvers. What are the shoulder dystocia maneuvers? Can you remember what those are? But this, the in situ simulation is, we're going to teach to this. Are we using closed loop communication? And I can guarantee you that you will not be using it 100%. Are we using standardized language? I can almost guarantee that that won't happen. So that's the idea for the simulation, is that you have to teach to a curriculum, team steps being the curriculum, and this being the cliff notes, extreme cliff notes of team steps. So, situational loss, awareness loss, let's watch this one. This is from one of the earlier simulations that we ever did. And when I look back on it, it looks really rough, but it doesn't need to be beautiful to give you a lot of information. But basically, the doctor has been called to an emergency. The doctor has been called to an emergency. He was told over the phone that this pregnant patient is bleeding and having abdominal pain. The past medical history included that this patient had a previous child delivered by C-section at 34 weeks for a breech baby.
She came in, baby's heart rate was around 145 to 155. Not very good variability. Then it jumped up to 180s. Now it's back to 100.
We're not able to.
She said she wasn't having injury or trauma, but she feeling a lot of pain and some bleeding before she came in.
Can you tell me what's been going on?
Bleeding, a little bleeding.
A lot of bleeding?
A little bit.
A little bit.
Yeah.
When did that start?
Sometime this morning.
Okay. Do you have any other medical problems at all?
No, just like
The physician, upon entering the room, must multitask during an emergency. In this case, the doctor is introducing himself to the patient and significant other, receiving an update from the nurse, and evaluating the fetal heart rate tracing. Multitasking is one of the ways in which situational awareness can be lost. Listen carefully as the doctor asks how far along the pregnancy is.
I'm going to start at 9 p.m. Okay, get some fluids in.
Okay, so are you still having bleeding now?
Not too sure.
Not too sure, okay. You're how far along?
She's going at 20th.
So what, is her heart holding up?
She went down to a little dip here with a contraction.
The doctor's situational awareness is compromised by multitasking and the simultaneous response of both patient and nurse to his question. Confusion arises around the gestational age when there are multiple different ways to define it, such as a week away and she's due the 20th. No one uses a gestational age in weeks, but the doctor has heard a gestational age of 34 weeks, the patient's previous delivery, during his original phone call. Because of this variation in language, the distraction of listening to two people simultaneously, and the doctor's multitasking, the doctor loses situational awareness and is not clear on the gestational age of the patient. As will be seen, the clinical implications can be very different based on one piece of important information.
So,
What does that mean?
well, I'm a little concerned. Are you having a lot of pain or those contractions?
From the doors right now.
Okay. Well, I think you're in preterm labor. The baby right now looks actually okay. So I don't think you're really forced to do anything right now. The bleeding might be just because your cervix is dilated.
Okay.
How far along is she?
She's due the 20th. So the beginning of the 60s. So she's
Yeah.
40 weeks.
So we're almost term. Okay. So, well, I think we need to go back and do C-section. Okay. Okay.
What's going on?
Now going up to the
Today-
20th.
today-
They're back on our left side.
Okay, so that gives you an example of the in situ simulation and the way that we might utilize it to understand what's going on. Situational awareness is lost quite frequently when the leader of the team gets involved with tasks. So if you're the leader of a team and all of a sudden you're putting in the IV, you can't see the big picture. So the leader actually has to step back and not be working per se. that seems a little odd. Why is Dr. Davis not helping us with all the things we have to do? Because the best way for Dr. Davis to be Dr. Davis is to sit back and look at everything that's going on to make sure that something isn't forgotten or lost or whatever it might be. So I just show you that as a loss of situational awareness. This one I want to show you in terms of the problem with not using closed loop communication.
Next two labs, the skeletal section. We're gonna go in there. Press up and down, please. You need to get on tight, bleeding, okay.
Do we call somebody with O negative blood for baby?
Oh, sure. We need blood for mom.
It broke up no beat. I did some else and else.
Can you tie me up?
Go ahead and tap to a blood. O negative blood for baby.
Yep, and mom. I'm ready to say yes for mom.
Okay, everybody. Yeah, we need that. Couple units O negative blood for baby. Okay. Back in the C6. Bring the male stand over.
Okay, the problem was that they were asking for blood for both baby and mom, and you didn't hear a real secure closed loop of communication there. And what happened in that scenario actually was that the blood came up for the baby, but it never came up for the mom. And that's one way to understand your system too, is to get other people involved. So we had the blood bank involved with that. They knew we were doing a simulation, and we wanted to find out how long it would take the blood bank to get blood to the operating room, because I know that some of you have been in that situation when blood isn't coming quick enough, and that's very stimulating to your adrenal glands. So that's one issue. The next one, so we talked about situational awareness, that was closed loop communication. This one is about shared mental model. And I just want, this is again another simulation. They're coming into the operating room to do a stat C-section.
She's asleep? No, we will tell you when you can cut. She is not asleep. We want everything prepped and great before we do that. You know.
Okay, you're doing a C-section here.
Hard stop.
Filler.
Okay?
Okay.
That's right.
The lights on, the pressure 60.
Blood pressure 60. Okay.
Is the blood coming up?
The blood's coming, yeah.
We're running IV fluids rapidly. I think we still have to go ahead and just get started here. We're going to go ahead and put you to sleep now. We're giving the anesthetics. We'll let you know when you can do the incision. Pentothal is in. Succinylcholine is in. There's cricoid pressure being applied. We're going to intubate now. Go ahead and intubate him.
Okay. Have a relay ready.
Cords are visualized. High certainty that the tube is in. Okay, we're going to ventilate. Okay, go ahead and start the surgery. Yep.
Alright, I'll put her on the...
Okay, incision time, 9 o'clock.
Okay, so another simulation piece where you can look and see what's happening. And what the doctor, well, I should ask you guys, what did you like about that?
Anesthesiologist was telling the surgeons what was going on all the time.
Yeah, exactly. He was thinking out loud, wasn't he? And he was thinking out loud in terms of his induction, wasn't he? And the thing is, that's really standardized language. I mean, I know what succinylcholine is. He didn't call it, oh, I'm going to give this agent that blocks the diaphragm, whatever it might be. And what happened with that is by sharing his mental model, the OB team, who was behind this drape, right, don't even know what's going on over there, is able to then know, okay, there's actually kind of like a NASA countdown, 10, 9, 8, that's why I put that in there, so that they can get ready because they know when they need to go. So by sharing his mental model, they were able to move more quickly be more organized for when they needed to get going. So when that question I asked, that's really the first of 3 questions in a debriefing, is what went well? You could say, what do you like? But what went well in that simulation? The second is what didn't go well, and then the why. And then what should we do next time? What would we do next time? And those are the 3 debriefing questions that you can use for anything. A kid's soccer game, camping trip, a shift, a nursing shift, a doctor's shift, a patient's care throughout the hospital. So the debriefing is a very powerful way to learn. It's about process improvement. So I said that there were individual skills, there are also team skills, and very briefly, the 3 team skills you really need to have is that you need to brief, you need to have huddles, and you need to debrief. And very quickly, a briefing is about planning, something that a lot of us are used to doing in the morning per se. I have this patient, here's what I think is going to happen, here's my goal for this patient, who is all on the team, and do we have any questions? So the first thing about briefing is you can remove a lot of the phone calls to the clinic. That's what's in it for me, is by really giving a good briefing. I'm not going to get all these calls from the nurses later because we already discussed the plan of care. Secondly, a huddle, and I like to call this the OMG moment. And for those of you who knew Marcus Welby, OMG means, oh my God. And so the idea is that something happened. Somebody at least laughed at that a little bit. I know it's early morning, and I'm not the best morning person, but it's an OMG moment in that you have to get back together and say, okay, what's going on? Christy and I have seen enough of these where we want to work, especially in an emergency. But what can really help when something has changed is for someone, i.e. maybe the leader or someone else steps back and says, okay, where are we? What's been given medication-wise? Where are we going? Did someone contact the operating room? So you just take that little small amount of time to actually stop working and actually get back to a plan. Debriefing we've already talked about, and good teams debrief. Who does this really well? What can you think about? What institution, not institution, what business or whatever does this well? I've got so much to tell you. I feel like it's what I did over the summer. I just want to tell you guys everything I did over the summer. So I'll just tell you, football teams do this really well, don't they? Now the Vikings may not be doing it very well. But who's good right now? I guess the Seattle Seahawks are really good right now. So the Seattle Seahawks, before they play the Vikings, what are they doing? They're planning all week. They're briefing all week. Well, the Vikings got a really bad secondary. We're going to throw. And then we're going to have to watch Adrian Peterson, right? What do they do in the game? Well, they literally huddle. They call it a huddle because something's changed. They have to take time out. They're not doing the no huddle offense, which is kind of the way we do emergencies when I think about it. They're actually huddling because is it 3rd and 2 or is it 3rd and 20? They actually go in halftime and say, hey, we got to figure out what's going on because we're getting our butts kicked. And then lastly, what do they do on Monday? They review films. Say, hey, great tackle, bad tackle. So that's the idea. Good teams do these 3 things. I want to show you this. This is a montage of different simulations going into the operating room. And you'll see what I briefly mentioned before, which is that little bit of panic.
That blood up from the blood bank. Do you have an ETA on that blood bank? Here. And get the blood up here right now to the blood bank. We need it now. What's the status on our blood products?
Blood is on the way. Blood is on the way.
How's the blood?
We have blood going in yet?
Has she gotten any blood yet? Those first 2 units of blood are in. We have not received the blood. We haven't gotten them yet.
And we want to know where the blood plans are. That's when that blood is arriving.
We want to know the status of the blood and the blood.
And the blood is on the way.
We call the blood bank and ask what the delay on the blood is.
I need to talk to the blood bank.
Is that our blood? No, it's pretty good. It's not the number for the blood bank.
Can you tell
they give us some booties on cross-match, which seems quite alarming, but that's what we're told.
Units are on the way right now, right?
Okay, they've been on the way for 15 minutes. We want to go live.
Anyone recognize that? That's not fun. That's really not fun. And the reason that was put together, actually, what an assistant with us put that together, which I'm very grateful for, is it shows what you see if you watch enough cases in the OR and they're trying to get blood. One of the things here, and so you identified the problem. What the problem that you identified was we can't get blood to the OR quick enough. And there's confusion in the OR as to when the blood is coming. So what happened? Well, they went through a whole process improvement where they developed a massive transfusion protocol. And rather than asking, where's the blood, where's the blood, where's the blood, they said, we need to institute the massive transfusion protocol. The blood bank understands what the massive transfusion protocol is. You know that you're then getting O-negative blood, which should come up really within 5 minutes, versus typing cross blood, which comes up in about 40 minutes. Because they never knew for sure that blood bank was aware, probably closed loop communication, no one was able to create that accountability, and they never had an ETA. And so what happens when you keep saying, where's the blood, where's the blood, where's the blood? Lots of talking, lots of confusion, lots of fear. That's one element of teamwork and simulation, is to get your process improvement down. Show this one too in terms of briefing. This is from the TV show ER, which I never really got to watch because it was during my residency. So,
does anybody know when he's coming? How about a rough estimate? More than a minute, less than a hockey season. More than an hour, less than the lifespan of a giant redwood tree. Carter, hungry, thirsty, tired, cold. My arm just fell asleep.
Stop being a baby.
Plus, I feel like I'm hanging out of this thing. Someone cover up my crotch, please.
He's here.
We have a visitor. Don't remember being asked if Dr. Benton could scrub in for this.
I'm a friend of the patient. He asked if I would observe.
Uh-huh. Put him under. Let's do this.
Whoa. What about the checklist?
Excuse me.
Safe surgery checklist?
I've had 10 cases a day, Doctor.
All the more reason to take the necessary precautions. It only took a minute.
1 minute.
John Carter here for a right cadaveric renal allograft. Does the patient have a known allergy?
No.
Does anesthesia anticipate a difficulty already?
No.
Is the risk of bleeding greater than 500 cc's?
I sure as hell hope not. Let's go. Put him under.
Whoa. Everybody slow down. Now let's just take our time and introduce the room.
What's next? We all hold hands and sing Kumbaya?
Sheila Lane, scrub nurse. Paula Cheney, circulating nurse.
Kay Schumacher, anesthesiologist.
Randall Okerman, chief surgical resident.
Ethan Dean, surgical intern.
Peter Benton, observing general surgeon. Any concerns from the surgical team?
Melinda, you're wasting my time.
Any nursing concerns?
We don't have any reperfusion solution.
We won't be needing it.
I'll have some set up.
Were any antibiotics given in the last 60 minutes?
Just starting them now.
Pen blade.
Hold on. If you run the antibiotics prior to incision, you cut the risk of infection by half.
Dr. Benton, you're a guest here, and I don't like guests. As a friend of the patient, you're welcome to sit, observe, and shut up. Template. Middle venous anastomoses are complete. Releasing the clamps.
Suture lines look good, no leaks.
I voted yes for the ureter.
Shouldn't it be painting up by now?
What happened to sitting quietly in the corner, Dr. Benton?
No, seriously, shouldn't it be?
Sometimes it takes a minute.
I don't have a parenchymal pulse.
We've got an arterial thrombosis. Reclamp and take down the sutures.
Satinsky, please. Where's the clot?
Renal arteries obstructing the blood flow. Gonna have to take it out and start all over again.
Problem solved. Flush with heparin, saline, and reperfusion solution.
Reperfusion solution?
We've got it, we're all set.
Oh, well, it's a good thing we just have some lying around, huh? How long did it take to get the reperfusion solution up from the pharmacy?
15 minutes.
What happens if you don't have the reperfusion solution?
You made your point, Doctor?
No, I disagree, Doctor. I think that this is an excellent teaching opportunity. You'd have had 15 minutes of warm ischemia. The organ would have taken a major blow, and there's a good chance we would have ended up with a non-functioning kidney. Wouldn't you agree, doctor?
If we're all done teaching here, perhaps some of you would like to assist me in getting this kidney back into the patient's body.
Where do you get a copy of that checklist?
Now, people.
So, I love that one. It is Hollywood, but the idea on the briefing checklist and the operating room checklist isn't to have it work like that every case. The idea is that for us to be highly reliable so that that 1 in 1,000 case doesn't go bad. Because that is what happens, is that that 1 in 1,000 case does necessarily go bad. As a matter of fact, the error rate in healthcare is actually thought to be more like 1 in 100 of significant injury to a patient. So I've already talked about these 3 questions, but those are your debriefing questions. So when Christy and I have done this, these are some of the identified gaps or learnings from the in situ simulation. This one, obviously I don't intend you to read all of this, but this is actually interesting. We think our roles are really clear, but they're not, especially in an emergency. Because what happens is that we don't have necessarily, I'm nurse A, I'm nurse B, or I'm Dr. A and I'm Dr. B, in terms of this is what I'm supposed to be doing. It ends up being a little bit ad hoc in a way and not reliable. Here's some other ones. There are different things that happen too. When we first did simulation, we found that there were some dead zones for the beepers in the hospital. So that was an interesting little finding. Again, some of these findings are perhaps not related to your clinical care, but they're probing your system. And if you have a dead zone in the hospital, doctor doesn't hear the pager and is delayed to the operating room or whatever it may be. We also found that there were nursing behaviors that we could identify and look at. This is more of a rough estimate. Obviously the ranges are big, but what we found is, that was very interesting, is that an SBAR was only given about half the time, if even that, between the nurses. One of the problems there was that SBAR was sort of rolled out as a way for nurses to talk to doctors, when in fact SBAR is really a way for everybody to talk to everybody. And SBAR stands for Situation, Background, Assessment, and Recommendation, comes with a nuclear subworld, where the